Okay, we are talking about the cardiac biomarkers, specifically rise in the acute myocardial infarction. They are the diagnostic laboratory value, and the specific and the most sensitive one are the creatine kinase isoenzymes MB and the cardiac troponin I and troponin T. These are the most sensitive and the specific one. And the myoglobin, lactate dehydrogenase and aspartate aminotransferase. These are non-specific because the myoglobins even rise in the small muscles injury, lactate dehydrogenase rise in the small minor hemolysis, aspartate aminotransferase even rise in the liver diseases. That's why they are non-specific. And going to the specific cardiac markers, first we are talking about the cardiac troponin. Cardiac troponin and myoglobins, these are not the enzymes. The cardiac troponin I and the cardiac troponin T, their concentration are in the 5% in the cytoplasm and 95% in the myofibrils. Wow, why they are needed? Because in the graph, the onset is 4 to 10 hours and then rise up to peak level in 18 to 24 hours, and then they sustain release because of the 95% myofibrils cardiac troponin present in the myofibrils. This is due to sustained release. Sustained release does not take place in the creatine kinase. And the elevated cardiac troponin levels not only indicates the acute myocardial infarction, but it also indicate the cardiac injury. That is the stroke, pulmonary embolism, sepsis, acute perimyocarditis, and acute heart failure, tachycardia. That's why we developed high sensitive cardiac troponin. That means the 10 to 100% rise in the cardiac troponin T level needs further evaluation, and the more than 100% rise in the cardiac troponin T level, high sensitive cardiac troponin T levels, then we go through the acute myocardial infarction. The creatine kinase isoenzyme MB, it is dimeric, 2 subunit B, and the M for brain and the muscles, 3 isoenzymes. Among 3 isoenzymes, the MB that is present in the heart, it is just 5% in concentration. That's why it is 5% in the concentration among total creatine kinase. That's why instead of measuring total creatine kinase, we measure the isoenzyme MB. If we measure the total creatine kinase in acute myocardial infarction, the isoenzymes MB rise may not create difference in the total creatine kinase level. Total creatine kinase may be seen normal in case of acute myocardial infarction. Why? Because the creatine kinase MB level is just 5%, it may not create difference. That's why. But total creatine kinase rather we measure in the muscular dystrophies. The creatine kinase, that the reaction is it can convert the creatine phosphate to creatine, give the phosphate to ADP, converts it to ATP needs in the ischemia in myocardial infarction, myocardial cells, because there is no blood, no oxygen, no ATP synthesis. The creatine kinase MB doesn't rise in the hemolysis congestive cardiac, which is the advantage over the LDS. About the time interval is we are going to the creatine kinase CKMB. What is the importance of that? Firstly, it rises in the 3 to 6 hours. Then rapidly the cell starts synthesizing creatine kinase for production of more ATP. That's why the level rise in the 18 to 24 hours, but suddenly it falls because cells start dying, and then the creatine kinase level falls down. And the troponin, cardiac troponin level, it can rise in the 4 to 10 hours from the cytoplasm initially, and then it rises to peak level in 18 to 24 hours, and then cells start dying. The myofibrils degrading, and then the cardiac troponin slightly release, sustained release, because 95% present in the myofibrils, and degradation occurs, and sustained release of the cardiac troponin occurs. It is around duration around 8 to 14 days. And the myoglobin, the duration is the earliest cardiac biomarkers is the myoglobin. Around 1 to 4 hours it can initiate onset of myoglobin take place into the plasma, and then around 6 to 7 hours it can rise the peak level, and it in 24 hours it can fall down to a normal level. If we go after 2 days, and we cannot find in the myoglobin in the blood plasma, because it can fall down within the 24 hours into the normal level. Lactate dehydrogenase is the tetameric. As for heart and the emperor muscles. Why lactate dehydrogenase non-specific in the RBC? Lactate dehydrogenase catalyzes the reaction disease. In the RBC, there is an anaerobic reaction take place. It means from the glucose pyruvate to lactate. There is no Krebs cycles, no go through the Krebs cycle pathway. That's why there must be the higher concentration of lactate dehydrogenase, about 100 times more in the RBC than plasma. So a minor hemolysis can cause increase in the LDS enzymes in plasma. So it is not specific. Even the sternus exercise that can follow the anaerobic pathway and increase the LDS levels. That's why they are not specific. The LDS1 and LDS2. LDS1 is around 30%, and LDS2 is 35%. It means the normal value of LDS2 is more than the LDS1. But in the myocardial infarction, the LDS1 level, that means S4, the heart muscles S4 LDS1 is increased, and then LDS to around 5 to 10 times it can increase. This pattern is called peeped pattern. And about the myoglobin, they are non-specific, fluctuates during muscle injury. Advantage is it can rapidly rise and fall before creatine kinase and troponin. And the spotted aminotransferases, it is non-specific, even rise in the liver disease.